Good morning, everyone. I'd like to welcome you to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. Before I introduce our speaker, there are some housekeeping items that we need to attend to. First of all, we are broadcasting live via live stream and YouTube. For our in-person audience, please use the microphone to ask questions. The recording is always available for your viewing. You should consider subscribing to our YouTube channel to get notifications when videos are added. For our viewers, if you'd like to submit a question, text DeBakey to 37607. Again, that's DeBakey to 37607. You may also submit questions via the feed. Find the video on livestream.com/HMH-edu. Again, that's livestream.com/HMH-edu. There are a few conferences to update you about. We have a robotic vascular surgery summit, which is on March 25th and 26th. We also have the Heart of a Woman conference, which is on April the 27th, and our cardiovascular prevention conference on May the 4th. So please look forward to attending those. It's my pleasure to introduce our Grand Round speaker this morning, someone who I consider not only a visionary in the advanced heart failure transplant world, but also in research, but more importantly to me, a friend. Monica Colvin is the clinical professor of medicine and the medical director of heart transplant program at the University of Michigan, where again she specializes in the care of advanced heart failure, heart transplant, and left ventricular assist devices. The only one thing that we have to give concessions to Dr. Colvin, and please give her my sympathy, that Dr. Colvin did graduate from the University of Alabama. And as an LSU fan, we understand the inferiority of that institution, but we will still, acknowledge her expertise. She then went on to did her training at the University of Miami and completed her advanced heart failure fellowship at the Cleveland Clinic. As I said, she joined the University of Minnesota in 2002, where I had the pleasure of meeting and working with Monica, and actually she ran the heart transplant program as a medical director at the University of Minnesota there until 2015, where she moved then to the University of Michigan. Dr. Colvin, in addition to being an amazing physician, is also a very accomplished researcher. She conducts research and translational research on heart allocation, cardiac allograft vasculopathy, and rejection. She's a clinical specialist for SRTR and the clinical liaison of SRTR to the UNOS Heart Committee. She served on multiple writing committees and task forces, including those with AHA, ACC, and IHSLT. And she's currently an associate editor for circulation heart failure and the section editor for JACC heart failure. It's my pleasure to welcome Monica Colvin to give our talk, and she will speak on achieving equity in heart transplantation. Monica.
Thank you. Wow, thank you, Cindy, for that wonderful intro. All right, let's get this queued up. So, and thank you for having me here. Good morning. It's early. Our grand rounds are typically at noon. So, so as Cindy said, I will be discussing today achieving equity in heart transplantation. And this is going to be equity across the entire journey of the heart transplant process. These are a few objectives. We'll discuss disparities in advanced heart failure management, identify potential areas for equity across the continuum of advanced heart failure and throughout the heart transplant journey, and then discuss strategies for improving equity. So healthcare inequities have long been described in the U.S. It was, we've known about this for many, many years, but perhaps it was the events during the pandemic that pushed healthcare inequity and social justice to the forefront of our minds as we sought ways to improve conditions. And so we've all seemingly been inundated maybe with discussions about health equity. And when we talk about health equity, I think a lot of things come to mind. And this is just a word cloud that I found regarding health equity. Some of the things that kind of go with health equity: segregation, racism, barriers, providers, predictors. And I think many times we bring up these discussions we're all good people, we want to make things better, but sometimes it can make us feel a little bit defensive. What are we doing wrong? Is it me? Is it my practice? I'm doing everything right. What are you saying? Am I a racist? It brings up all these different sentiments. But I think as we look into this, we can see that there are different types of health inequities and different ways we can impact care for our patients to ensure that care is fair and just for all of our patients. So just going back to definitions, I think anyone now in 2024, having lived through the pandemic and YouTube and Zoom and TikTok, we all know what health equity is. But I do want to start out with some of the definitions. What is health equity, and is it just health equality, and what are the differences? And so the CDC describes health equity as a state in which everyone has a fair and just opportunity to attain their highest level of health. So I think that's probably the best description I've heard. Equity, this is from the OPTN, the Organ Procurement and Transplant Network. Equity refers to fairness in the pattern of distribution of the benefits and burdens of an organ procurement and allocation program. Here's another one that describes the difference between equality and equity. Equality is leaving the door open for anyone who has the means to approach it. Equity is ensuring there's a path to that door for those who need it. And this is along that path. Treating different things the same can generate as much inequality as treating the same things differently. So I think you get the sense that whereas equality is giving everyone kind of the same thing, equity has a component of justice to it, and it helps to ensure fairness for everyone. So if you look at the drivers of healthcare disparities, there are many social and economic inequities that drive disparities. So we can talk about disparities, which is kind of the differences in the outcomes, the differences in mortality, for instance, and the inequities are the factors that drive those disparities. So neighborhood, physical environment can lead to disparities in housing and transportation. Education, for instance, disparities in education or inequities in education can lead to disparities in literacy. Food access, for instance, can lead to disparities in healthy outcomes, and community safety and social context can lead to other types of disparities as well. So this is kind of the relationship between equity and disparities. Well, let's move on to heart transplant. As we know, there is a persistent imbalance in supply and demand in heart transplant, and these data are slightly old, but pretty much the same. And we know that the number of patients who are waiting transplant far exceed those who receive organs. So each year, now it's over 4,000 patients are transplanted, but then we have more patients who are added to that list, so we never ever catch up. So there's always going to be an imbalance between supply and demand. And then we look to the right and we see the sad, sad state of heart failure, which is essentially a giant sinking ship with lots and lots of patients that's been riddled by arrhythmias and LV dysfunction, RV dysfunction. And you see the tiny little lifeboat here that is mechanical circulatory support and heart transplant, really only has the capacity to help a certain number of people. And then you see all these barriers here, medical comorbidities weighing down the ship, psychosocial factors, economic factors. So the path to getting to transplant is a long and arduous one, and many, many barriers along the way. So I know that this is a general audience, so I'll explain a little bit. How does one get to advanced therapies? How do you end up getting a transplant? What is that process? Is it just that you send the patient on, they need a transplant, and we say, okay, sure, let's do it? And no, it does not happen that easily. So first of all, and I'm going through this just to highlight where along the way these barriers can occur. So first, we depend on a referral to an advanced heart failure center. So that means a patient has to be recognized as having heart failure. And as many of you know, there are delays even in the diagnosis of routine heart failure. Heart failure can be misdiagnosed as asthma, for instance, for many years, leading to the delays in diagnosis. But then the physician has to recognize that this is an advanced heart failure patient. What actually defines advanced heart failure? Once that determination is made, the patient is then referred on to a specialist, like Dr. Martin and her team, where they undergo an evaluation for transplant or advanced therapies, and a decision is made then. Is this patient appropriate? And we'll talk a little bit more about the evaluation process, what constitutes an appropriate patient. But a decision is made at that time, again, a point where a disparity or inequity can occur, and a patient either goes on to advanced therapies or they continue on medical therapy. Finally, there's the evaluation process that can be subject to or open to subjectivity. There's the committee meeting, which is required by CMS. And this is a multidisciplinary meeting where everyone gets to weigh in on transplant eligibility. A decision is made, patient is listed. It doesn't end there. Something can happen in that stage. And finally, the allocation process. And again, barriers can happen anywhere along this path to transplant. In the management, we talked about recognition of heart failure. We know that there are disparities in the medical therapy of heart failure, in referral practices. So that's one point. Access, eligibility, insurance, implicit bias, all of these things can limit access to a referral center or to a transplant center. What about the evaluation and listing process? There's center behaviors, policies that can impact listing, that can impact allocation and transplant, and then there are biological factors that are frankly out of our control. So just going back to management, we talked about racial and gender disparities in referral patterns, and this is looking beyond that. What about our critically ill patients? How do we manage our critically ill patients? This is a study that was published by Dr. Breathitt, where patients with heart failure are admitted for ICU care. And what she looked at was, were those patients managed by a cardiologist? And you can see, I will go back a little bit, that African Americans were, sorry, that's a typo, were less likely to receive primary ICU by a cardiologist compared to whites. So if you look at the graph on the right side, it shows the tendency to receive care by a cardiologist in the ICU, and you can see that blacks were least likely to receive that care by a cardiologist. And the question becomes, is that really important? Do you really need to see a cardiologist in the ICU? And yes, the answer was yes, because if care was administered by a cardiologist, this was associated with improved in-hospital survival in both blacks and whites. And I think this has been demonstrated over and over, that you can eliminate disparities in outcomes when you deliver appropriate care. This is another study looking at patients who presented with ST elevation MI and cardiogenic shock, looking at not only racial differences, but also gender differences. And as you can see, women and blacks tended to have higher in-house mortality, but also were less likely to receive interventions that could reverse the course, revascularization, for instance, mechanical circulatory support, and right heart catheterization, those types of procedures that are really integral to the management and treatment of advanced heart failure. Well, many complex factors can coalesce to impact access. So we're moving on to access. Just getting into the door is a point of access, and then once in, getting access to the treatments. And so we can see here that race, sex, insurance status, adherence, all of these things can create disparities in access. So let's look at insurance. Because this is one of those things I think we feel that we know, but the question is, does insurance really affect access to transplants? So this is a retrospective analysis of heart transplant and LVAD evaluations between 2012 and 2016. This is looking at Medicare and Medicaid data in Georgia. And they examined the association of insurance type with treatment eligibility and 1-year survival. And what they found in this study was, number one, that Medicaid patients tended to be younger, they were more often black, that fewer comorbidities, so kind of an optimal patient in some senses for advanced therapies, being young with no comorbidities. But they found that Medicare and Medicaid predicted a lower odds of eligibility for heart transplant. They also found that Medicaid patients were less likely to receive destination therapy, VAD, and when they didn't receive destination therapy VAD, they had significantly worse mortality compared to those who did. Medicaid was also a predictor of lower survival in those patients who were not listed for heart transplant despite having fewer comorbidities. So if you look at the graphs here, when patients received transplant, there was no significant difference in survival. But if you're looking here, you can see the discrepancy in outcomes between those who had private insurance and those who did not when they were not transplanted. One thing I did want to point out is another area of disparity to me is that health insurance is required for heart transplant eligibility. So whenever someone comes to us for a transplant, if they don't have any way to pay for the transplant, they cannot be transplanted. And but we don't require that for donors, right? So about 1/5 of donors are uninsured. So you have patients who are donating their organs who may never be able to benefit from the system. So just something to think about. Another study looking at private insurance versus public insurance. And no matter how you look at it, so if you have continuous private insurance or you transition to private insurance, even after adjustment for education, for donor and recipient factors, etiology of heart failure, et cetera, your mortality after transplant is a lot better if you have private insurance compared to those who have either continuous public insurance or compared to those who transition to public insurance. So, the question is, why is that? Is this a patient factor? But in this particular study, those factors were adjusted for. So another point of access we talked about is the decision process and the decision-making process, determining eligibility for transplant. So this is a study that one of my colleagues performed. It's an evaluation of the Revival registry. The Revival registry is a 400-patient multi-center registry that enrolled patients who had heart failure who might require LVAD. So the purpose of the registry is to understand the trajectory of patients who have heart failure who might go on to need LVAD. And so what we found in this study is that Blacks were 55% less likely to receive LVAD in transplant. And this was, again, even after adjusting for heart failure severity, quality of life, social determinants of health, and despite similar care preferences. So I think a lot of times we talk about disparities in care, and the question is, well, maybe it's the patient, maybe they don't want this, or maybe it's something with social determinants of health. But we did adjust for all of those factors here, and we saw even after that patients were less likely to receive advanced therapies, which raised the possibility that there's residual inequity, possibly due to structural racism or discrimination or provider bias that was impacting decision making. The good news is, despite that, mortality did not seem to differ between Blacks and whites. This is another look at heterogeneity in decision making in patients who require advanced therapies. This is an evaluation of Medicare beneficiaries between 2008 and 2014. And the goal of this study, again, was to look at risk-adjusted inequities in access and outcomes for both Black and female patients, and to try to examine the decision-making process. So the way we looked at this was by the propensity to for needing an LVAD. So you have patients who are straightforward, who present to you, they have all the medical criteria, very easy decisions. I think many of us will find that the challenge is with those patients where the decisions may not be straightforward. So in looking at this, I'm going to start at the bottom here. If you look at the patients who had a low propensity for needing LVAD, so this is looking at Black patients and white patients and female patients, with 0 representing white patients, what would be considered the standard. On the low end of the spectrum, and those patients where the decision might not be clear-cut, compared to white patients, Blacks were less likely to receive a VAD in that situation. When you got to this end of the spectrum, then the decisions were pretty easy. For women, however, along the entire spectrum of propensity, they were less likely to receive VAD compared to their male counterparts. And if you look at readmissions and survival, blacks actually did well, and women actually were about the same across the spectrum of propensity. So this raised the question of if the decision comes down to the gray area, right? Not the straightforward case, but those gray areas. Are we making decisions that are detrimental to women and to black patients? So the evaluation process is probably one of the most contentious parts of the process for transplant physicians. If you've ever had an opportunity to attend one of these meetings, everyone's advocating for their patients. We want to do the right thing. We want to help our patients. And meanwhile, you have the transplant director who's trying to respect the policy and the rules and make sure, you know, the outcomes are good at 1 year and 90 days, et cetera, et cetera. But one of the CMS conditions of participation is this patient selection process. And what CMS requires is that we assure fair and non-discriminatory distribution of organs, that there is a psychosocial evaluation, so this is a big piece of it, that we include documentation about blood type, at least on 2 separate occasions, and that there's documentation in the medical record of the patient selection criteria that's used. So this is a way to ensure that there's uniformity and consistency in practice, and hopefully that there's fair and non-discriminatory practices. But the psychosocial evaluation piece is the part that's really prone to subjectivity and tends to be the crux of many arguments in transplant meetings. The goal of this meeting really is to determine candidacy. So we walk into this meeting, are they medically appropriate? Is it surgically feasible? I think those are the 2 questions that we can answer pretty easily. Are there any contraindications? Then we have our list of contraindications, but it gets a little fuzzy. You know, smoking, when did they last stop smoking? There are all these things that are relative contraindications. Do they have appropriate support systems? Again, this is an area that can be vulnerable to subjectivity. What is a support system? We often require that our patients have care 24/7 for a month to 3 months, depending on the situation. Where does that support come from? Well, not everyone has a spouse who's willing to be there for them 24/7 or any type of caretaker. So many times we have to cobble this together. I have a patient who has a 16-year-old daughter taking care of him, and that sounds, you know, a little bit extreme, but she was highly competent, knew more about the process than her dad did, and was a very good caretaker. Is the patient a good steward of the organ? Again, how do you determine that? We base that on things like adherence. Are they taking their medicines now? Are they showing up for appointments? And then again, the psychosocial evaluation that's performed by our social workers or sometimes a neuropsychologist. So the goal is to identify the best potential recipient with the highest probability of achieving maximum benefit and also a good outcome for our programs. So it's a pretty arduous task. So I mentioned some of the pitfalls of this process. Number 1 is that it's vulnerable to subjectivity. We have the social work assessment, and then there's our input. Well, how much is too much to be drinking? You know, how much is too much alcohol? Things like that. We have ways to measure adherence, but do we always stick to those things when we're faced with a patient? Women are less likely to be eligible and listed, and that's been demonstrated in a study by Dr. Breathitt, who's done a lot of work in this area. There's a differential perception of support for women versus men. So women are typically caretakers, right? We take care of our kids and the husband, et cetera. And as such, because we're doing all those things, many times we're seen as not having support ourselves. So that's one area where the psychosocial evaluation can fail us. African American women are judged more harshly regarding social support. And as stated above, children tend to be liabilities for women. So We might have a male patient who has 4 children, and we'll say, oh yes, we got to transplant this guy, he has 4 children. And then on the flip side, you may have a woman who has 4 children. Wow, how are we going to get through this? She has all these kids, who's going to be her support? So it's really about the perception, and is there a way to standardize this? This is a study, again, by Dr. Breathitt, who has done work in the area of healthcare equity and advanced heart failure therapies. And she's done 2 of these studies. This is one where she attempted to determine how much race influenced decision-making for advanced therapies. So she sent out these vignettes to members of the Heart Failure Society, to providers, and the vignettes contained 2 scenarios that were identical medically, but the patients were identical aside from the fact that one was black and one was white. And so she tried to make them look the same, the clinical information was the same, and the idea was you read the vignette and you determine whether this patient qualifies for LVAD or transplant or whatever. And so she delved into the decision-making process a little bit. And did she find any major differences? Were people just terrible and, you know, this person only gets this therapy and so forth? And it was not like that, but what she did find was that race did impact every decision, every step of the decision-making, sometimes in a good way, sometimes in a bad way. So there was concern, for instance, that the photos might contribute to negative racial bias. There was some participants developed negative reactions to the white patient, but not to the black patient. There were concerns about adherence, greater concerns for adherence for the black patient versus the white patient, and so on and so forth. They're all listed there. There was a tendency in healthcare professionals who were 40 and older to oppose heart transplant in black patients, and there was a trend. So it may be age-related, I guess, in our profession. But what we did find out, I think this was kind of an initial step at looking at the evaluation process and decision-making and just opening the conversation, and she's done other studies. We're participating in one. Moving on to pediatrics, we also see that bias affects decision-making in pediatric patients. So this is a cross-sectional study of transplant physicians from the Pediatric Heart Transplant Society, and they conducted surveys and used the implicit association test. So I don't know if anyone has ever had a chance to do it. I saw this and thought, oh, let me try that. It's kind of interesting. You can find it online. It's conducted by Harvard, and you're basically asked to associate words and pictures, and you basically have to do this very quickly. So you might see the face of someone or 2 faces and the word angry, and you pick one. And so it's designed to determine whether or not there's implicit bias. So this looked at implicit bias and explicit bias. And what they found was there was a preference for white individuals in the decision-making process and a preference for those with higher socioeconomic status. So in that regard, there's implicit bias for those who appear to be better off. There's also explicit bias for those with higher education. So bias also affects the pediatric transplant process. So finally, we get to allocation and transplant. So a patient has made it to this point, they've been evaluated, and now they're at the point where they're going to be listed for transplant. And so out of the realm of the decision-making process, but there are other factors that can impact their access. And so geography being a major one, organ donation, organ allocation policies, center behaviors, as many might know. Even though we have policies in place, there are the things that we cannot track that happen at different centers. Which organs are accepted? That may depend on who's on call, how tired they are, et cetera. Some decisions are made, based on the patient, and those are things that cannot be captured based on the candidate. So, and biological factors. So these are data from SRTR, and as some of you may know, I'm part of the Scientific Registry for Transplant Recipients, which is the national registry that manages all of the data for solid organ transplant. So every year we publish a report that describes the trends in organ transplant and allocation. So this is from the 2022 data. So, and this trend hasn't changed. We know that transplant rates have increased, and it's increased in all groups, although there still remain disparities in transplant rate. So this is a study that looked at disparities in the likelihood of transplant. So we know that transplant rates have increased overall. The new policy was designed to increase transplant. But is this true for all? So when they looked at the likelihood of transplant by race, we saw that blacks were significantly less likely to be transplanted, even after adjustment. Waitlist death seemed to be a little bit less, and significantly so in blacks, but post-transplant deaths seem to be significantly higher. So we're still seeing some disparities in getting to transplant and also post-transplant outcomes. This is looking at patients who received a VAD as a bridge to transplant. So these are patients who really should go on to get transplanted. And so what happens in these patients? Again, this is stratified by race. This is a group of patients who have continuous flow LVAD. And when you look at waitlist outcomes and death, you can see that there's a disparity here. Blacks were much more likely to die while awaiting transplant and less likely to receive transplant. And these are significant differences. These disparities translated into increased waitlist morbidity, but not necessarily post-transplant survival for those who actually got to transplant. So again, if you receive the therapy and if we administer those to everyone in an equitable way, we can reduce the disparities in outcomes. This is a similar study evaluating disparities in bridge to transplant LVAD by gender, and this is a UNOS analysis. And for those who don't know, these UNOS analyses generally include over 30,000 patients, so they're huge databases. And what we saw here is that women were significantly less likely to be transplanted. So they have an LVAD. The LVAD is intended as bridge to transplant, and they're less likely to be transplanted. Their waitlist mortality is 50% higher than that of men, and they're more likely to be delisted for worsening clinical status. And again, all of these achieve statistical significance. So you're not out of the woods once you approve someone for transplant. Geographic variations in access and outcomes have been present forever, and the policy has evolved many times to try to improve these disparities. I'm just showing on the left hand in the upper graph here, just heart failure death rates. So this is not UNOS data, but this is just a look at what's happening in our country and the wide variability in death rates and where they're concentrated. I grew up in the South, and I know the South has been, the stroke belt and the heart failure belt, and you can see here there are high rates of death from heart failure. So if we move down to here, this is heart transplant rates. Your access to transplant not only depends on all of the things I mentioned before, but it also depends on where you are in the country. You may be at one of those centers where the transplant rate is very high and your wait time is very low, and therefore you survive, you make it, and everything is good. Or you might be in one of those states where the transplant rate is excessive, and you can see as it gets darker, the transplant rates are lower. So moving over here, these are pre-transplant mortalities based on geographic region. So your wait list death, that also varies pretty significantly by region, from about 5.9 or 0 in some places, all the way up to 44.6. So which state would you rather be in waiting for your heart transplant? But many times our patients don't have a choice. You are where you are, and you just have to wait. And again, another way to look at heart transplant rate is heart transplant within 1 year. And again, that varies pretty significantly from about 42.3% to 100% of patients being transplanted within 1 year. And you can see California does very well in that. And if you look in the middle of the country, maybe not so much. These are data from one of Dr. Breathitt's studies looking at heart transplant to heart failure ratio and imbalances in this ratio. So this is basically looking at the number of heart transplants per 100,000 population divided by age-adjusted heart failure mortality. So what she found was that blacks had lower heart failure, heart transplant mortality ratio compared to whites, and Hispanics were pretty similar. You can see the greatest disparities in the Midwest. And again, factors that might be beyond the patient's control, such as wait time and access to organs. I know since I've been in the Midwest, I feel as if our wait times tend to be quite a bit longer than, say, the coast. Other challenges, biological differences, sensitizations. Sensitization refers to the presence of circulating antibodies that a patient has that can limit their access to transplant. It limits the ability to find a suitable match, and it increases the risk of having rejection after transplant. 30% of transplant candidates are sensitized, and pregnancy, transfusions, vaccines tend to be risk factors for sensitization. Sensitization disproportionately affects women, and blacks tend to have higher levels of antibodies. They're more likely to be sensitized and have greater HLA mismatches. Well, why is this a problem? We don't actually have any standardized approaches to treating patients who are sensitized. So the therapies that are available are not available everywhere. They're very costly, ranging from tens of thousands of dollars to hundreds of thousands of dollars. Not everyone is an expert in using these drugs. And so many times we're tasked with trying to find ways to get these types of patients transplanted, or simply saying you're not a transplant candidate. There are centers such as Cedars-Sinai where they're experts in this therapy, but not everyone has access to Cedars-Sinai for a variety of reasons. Multiple listings. This is a policy where patients can be on the list here in Texas and can come up to Michigan and say, hey, I also want to be listed here because I have family, and maybe there's an advantage to be listed in multiple places. So a transplant hospital can decide whether they will accept you for multiple listing. So again, there's a little bit of subjectivity there. The widespread use, however, undermines equity because not everyone has access to multiple listings. And current utilization patterns, when this was evaluated, aligns with socio-demographic disparities. So although this is great for our patients, it does contribute to inequity in care in some regards. So what do we do? How do we move forward? We know that these inequities exist. We know it's along the entire trajectory for advanced therapies. What can we do? So first, I think, I didn't put this here, having just a conversation, talking about it openly and honestly within your transplant program, but also reaching out to the community and to your patients. Shared decision making may help to eliminate some of those inequities, understanding what your patients want. Community outreach, reaching out to those referring physicians who, again, may not see what we see on this side, may not understand when to refer a patient for advanced therapies, but also may decide themselves who's appropriate. So I think community outreach, education will help. The spoke hub model clinics, I think that can be beneficial. And I mentioned here community-based practices. There's a model with the Grady Heart Failure Program. This is by Dr. Modele Ogunai, who developed a heart failure clinic in an underserved area. And sounds like a disaster, right? You might lose money, patients might not show up, it might be very challenging. But what she saw was this was able to reduce readmissions and actually turn out to be profitable. So these models exist. There are ways to administer this type of care. It's important that we, as transplant physicians, examine and standardize our practices, incorporating social determinants of health into our evaluation process. There are ways to do this. There are tools that we can use, such as SciPet, that can help us standardize our assessments of patients. But they're not routinely used, but I think it's something that we should probably be turning towards. The social heart failure trial is a study led by Dr. Brett that we're participating, where centers will be randomized to receive an intervention, which is a behavioral therapy or behavioral intervention, versus continuing along the way that they've always done. And so the evaluation process is recorded in this particular study. We send these recordings, they scrub the recordings and pull out these data and try to understand the decision-making process and determine if there are biases or not. And so then there's an intervention, and then the meetings are recorded again to determine whether the intervention was successful. So there are people who are actively looking at ways to improve the evaluation process. The International Society for Heart and Lung Transplant has actually made recommendations for the content of the evaluation process. And I know that this is published, but these are probably things that we're not routinely doing yet. There has to be a critical review and revision of policies, and going back to those policies that may contribute to disparities. I mentioned here the elimination of race-inclusive GFR for kidney transplant. So many of you know we've been using race-inclusive GFR forever, and I don't think anyone has questioned the practice as much until relatively recently. And so what they found was this probably is not the best way to assess patients for kidney transplant, and it was overestimating kidney function in about 15% of patients. And so they had to go back, look at this, and eliminate the use of race-inclusive GFR, and they had to make some changes to the policies and also make updates to patients who were listed for transplant. So, you know, there are things that we do because we've always done them. And if we never go back and critically review them, we'll always do them and create these types of scenarios. But the kidney transplant community has done an excellent job in remedying that. In our world, one example would be sensitization, something that we've known could potentially create inequity in access, but have not really understood how to manage it. And so as our allocation policy evolves, this will be part of the policy and hopefully will allow patients who are sensitized better access to organs. On a policy level, the Organ Procurement and Transplant Network has identified as its strategic goal to improve equity in transplant opportunities. And there's a whole list here. I won't go through the whole thing, but this is a priority for the OPTN. And one thing that they have done, this is kind of an interesting exercise, if you go to their website, you can see in real time some of the metrics that they're monitoring for disparities. And you can see how they change over time. This is, I looked at this before, but some of the metrics that are being followed, blood type, for instance, donation, service area, let's see here, education, and diagnoses, and how these are impacting transplantability and access to transplant. And you can see here the variability with donation service area has actually decreased over time. So this is, again, the geographic component of access. We can see that there's been improvement, although when you look down here at gender, variability in access to transplant based on gender may have gone up during this period. So this is an interesting tool where you can easily see what's going on in the transplant world. So as a path forward, I think we have to prioritize equity. We have to talk about it, and it has to be built into our system. If we feel that the way we evaluate our patients is prone to bias, then we have to change it and come up with a standardized way to do that. We have to create systems that can eliminate biases, and they exist. There are models that can improve clinical care, at the same time can eliminate bias and improve disparities. Culturally targeted interventions can also help to eliminate disparities. We should also increase representation And we talk about that a lot, increased representation amongst our doctors, but also among the decision-making on a national level, and institute transparent and unbiased policies. I mentioned kidney transplant. Continuous distribution is the new model for heart allocation that may help to improve disparities. So I'll end with this, because we talk about this a lot, but the question is, what are we going to do? So as a medical and scientific community, it is time for our actions to move beyond describing and acknowledging inequities. Rather, we must commit to enacting solutions that rectify inequity through multidimensional approaches that address fundamental causes. And these are hard things. These are very hard things to do. It requires kind of digging deep and self-reflection. But as someone has said before, these things will be hard, but we, being very smart and highly trained people, can do hard things. And speaking of hard things, I have to mention this. Cindy mentioned Alabama. This was pretty bittersweet for me, but it's still good to be affiliated with a winning team. Thank you. And that ended early. Thank you.
Thank you so much, Monica. We really appreciate a very, I think, enlightening and I think challenging presentation, adjusting, and bringing light to issues of places that we can improve. Before we jump into questions real quick, I did forget to mention one meeting that's coming up, actually one of our own. So the 9th Annual Heart Failure Summit meeting is actually this Saturday. And so there are in-person as well as virtual options available. So for anyone who's interested, please look at that. We'd love to see you on Saturday to talk more about heart failure. And with that, we'll open it up to questions.
No, Colvin, thank you very much, and congratulations for leading this important but difficult field. Because I think some of these implicit biases that you mentioned, I feel, are ingrained in human psychology of having patterns of, somehow subconsciously associating everybody who looks the same. So it's a tough challenge to assure equity, but I think it's a challenge that has to be taken up. My question to you is specific to heart transplantation. Sometimes our protocols of care seem extremely burdensome, and they're designed for appropriate oversight of the organ. But is there an opportunity to redesign these? Because there are times where the financial burden, you have to come every 3 months, you have to come every 6 months. And these, I feel, have been designed historically with an intent to care for the organ. But have we not adapted to the current day and age of virtual visits and redesigning ourselves, especially for VAD? Like the last 20 years I've been in training. When VADs first started, we were so nervous, like we just wanted to do everything so on top of things. Mm-hmm. But they've evolved, the technology has evolved, but I feel across the centers, the care burden protocols might not have been relaxed. So I don't know if this is something I've never heard us talk about in the society level, saying, should we look at centers that are burdening the patients less, and are the outcomes still okay, and can we learn from each other?
Right. No, that's a very good question. It's a huge burden on our patients to, with LVAD, with transplant, to have a caregiver 24/7, to come back frequently. And the other thing that we're seeing now, so the policy has changed. Many of our patients are transplanted as inpatients, from devices or status 3Es. And they stay in the hospital for months on end. And after that, they're mentally drained. And so what we're starting to see now is, rather than patients dying on the wait list, they don't want to come back. They've spent, half a year in the hospital, and they have no interest in following up every week for a biopsy and every other week. And I think that's a really good question. Can we change our practice to accommodate the technology that we have now to do virtual visits? And I think that would be a great model, and someone should investigate it. I think everything we do so much that we do in transplant, right, is not data driven. It's consensus based, or it's based on what everyone's been doing forever. They were trained by this person who started the field of transplant, and that person trained them, and we're just going to continue to do it the same way. But I think you're right. Somehow eliminating that burden on patients would help.
I can just make a little comment about something similar to that where we saw, personally I've seen a big changes. And Monica, you helped start this when we were at the University of Minnesota, of having these outreach clinics. And I will use the outreach clinic that we had in Mason City, Iowa as one of the best examples. And this is a small town in North Iowa that's about 3 hours away from Minneapolis. And Monica actually started that outreach, and then I got to take it over after she transitioned to Michigan. But we create a system to where our LVAD patients who lived in that area, we would see them in Mason City in their own area, and they didn't have to come to the city. They didn't have to drive into Minneapolis except once a year. And seeing the adoption of patients take that up, these old farmers who are like out on their combine with their VAD who don't want to drive to the city because the traffic is horrible and the crime is everywhere. And I'm like, it's Minneapolis. But seeing that change and that cultural thing, that made a huge issue. And so I think we do have, an opportunity to bring technology to our patients as opposed to making patients come to us. But I think it is challenging when it comes to certain things like transplant because of just resources that we need. But I think...
Yeah, and our nephrology colleagues have done that. So I actually have an outreach clinic in Midland, Michigan. And we have not done transplant there. We only do heart failure clinic there. But I know the nephrology team has outreach clinics where they actually see transplant patients and do evaluations at other centers in the state. So I think there's huge opportunity to do that. I think it's just we're so afraid to let go of those reins. I'm already thinking, gee, what could possibly happen? But it is possible to deliver care in a different model. Yes.
Yes, my question is regarding international patients. I was practicing overseas, and some patients can afford coming, and they request specifically coming to the States for heart transplants. So I did my training in the States, so I was under the impression that you have to be, either a U.S. citizen or a green card holder. But then I saw some patients who had their transplants. So can you tell us a bit about that and the ethical implications as well?
So that's a good question, and I have not actually had to deal with that since I've been in Michigan, at least not recently. But we did in Minnesota, and so transplant programs are allowed to have, I think is it 5% or 5% of patients that are international. And so it's a double-edged sword, right? There are ethical issues, and I know when we did this in Minnesota, and I was very eager to start this international program because I think Kidney had one at the time, and I trained in Cleveland, so we had international patients all the time. Now, transplant is a very expensive business. So when you have patients who can pay, this helps the program, and it helps all of the other patients. And but it's tricky because then there's this sentiment from some people that, wait, someone's taking an organ from me. They're taking an organ out of the system, and it should be for us, for U.S. citizens. So I look at it like this. I think it can be beneficial to programs. We were just looking at cost recently for transplant, and the overall cost is well over $1 million. It's not cheap. And you have patients that you want to help who might not be able to pay, and sometimes hospitals will eat the costs of those patients. So I think there has to be a healthy balance there if you're able to do that. And I'm talking just about the aspect of compensation, but I think it is important to be able to provide access to patients outside of the U.S. as well, if there's a limitation, absolutely.
Very much appreciative of addressing this topic, which is very important, challenging. I think you've touched upon so many factors that influence ultimately the outcome on what we do. And it is a challenging population. And the question to you is, have we moved the needle over the past few years in a more appropriate direction, knowing all the challenges? And two, whether now there is a focus towards it. Is there a mandate, one way or another, for transplant programs to look at their data and see if they can harmonize it in the direction that it should be.
I think the needle has moved. So we're seeing disparities narrowing in the transplant world. And the challenge with this type of research is what is the denominator? And I know that there's going to be a paper coming out that looks at a population eligible for transplant or who have heart failure. But many times we're looking at prevalence when we look at transplant data. And we assume that to be disparities. So it's a little bit tricky, right? But we are seeing that there are more minorities that are being transplanted. We see that outcomes are improving. There's not as much as a separation. So I think we're moving in the right direction. As far as decision making, I think that still is up for debate, and some of the studies are going to answer those questions. I think just having the conversation, right? So if this were 10 years ago when we didn't have these data, we might have said, we think that occurs, but we didn't have anything, any basis for it. And now we know that our decision-making processes might be biased. So I think that moves the needle in and of itself. And as I mentioned, the OPTN has made this a priority. So I think the fact that the OPTN is making equity a priority really compels the programs to do more.
Right.
I'm Brian, one of the heart failure transplant cardiologists. Thank you for bringing this important topic. I think I also want to address and I also concerned about decreasing the interest in a heart failure. And I think that goes with the access issue as well. I always struggle when I ask my patient to come move us, his family had to relocation. I think that really affects who we can transplant as well. And now we also are going to be facing with decreasing interest of the people who want to go into the heart failure and training. I just want to get your thoughts about what can we do, as far as in a society level and in the cardiology, to improve this access instead of, discouraging people going to the heart failure and transplant training.
Right. So interesting. So I know there was a paper in JCF, right, that talked about the waning interest in transplant, and it was almost, this is alarming, and we need to do something. And we at CIRC also wrote an editorial. We didn't think that this was really the end of the world, right? Because how many advanced heart failure doctors do you need? How many transplant physicians do you need? I don't know that limits the access for advanced therapies, because I think what's needed is more heart failure physicians, perhaps, more of the gatekeeper type physicians. But that being said, and I think this is just a phase. I think the interest will increase again. But how do we increase interest in the field? I think there are many reasons people are interested. If they're only going to do heart failure and they're not going to do advanced therapies, why do an extra fellowship? Why not just go into private practice or wherever, make money, forget the extra year, and that's that. So I think that's one thing. The compensation is another issue. And now we are divvying up the practice of advanced heart failure, right? So you have to be an intensivist to manage patients in the CCU. And so people are doing critical care training now. And so that kind of took away that group of patients. Like when I trained, we were in the unit all the time. When I joined faculty, we were in the ICU all the time. Now I'm not really in the ICU. There's a group of people who rotate in the ICU. So that's kind of eliminated what was the most exciting part of advanced heart failure. So, can we go back and take ownership of that? I think that's going to be really challenging, But I think there are other things.
One last question, yes.
I have one more, but.
Okay, great. Thank you, Dr. Colvin, for this presentation, so relevant. Some numbers are hard to see. I'm Valeria Duarte. I'm an adult congenital cardiologist and a proud woman, Hispanic woman in cardiology. So my questions for you is, you presented data that really exposes bias at the time of selection. And at the same time, you suggested that we need to improve our outreach and our efforts to improve those numbers. But how do we drive that? How do we achieve that when the minorities are so dramatically underrepresented in our healthcare force? How do we change that from the root? I know that Mass General, for example, just started a funded fellowship. So one of their cardiology fellowship positions is funded for minority fellows. So I think that's a great step, a great start. But how do we work on this from an institutional level, from a society level? Because I think that will be a very important driver to achieve change.
No, that's a great idea, funded fellowship. I tend more to engaging the community. And so our nephrology partners have established a clinic in Detroit, for instance, and they partner with community physicians there. Because I think that really is where you can have a huge impact. Having worked in Minnesota and with the Hennepin County people, you can see like the patient populations that they see are so markedly different from what we saw at the university. And they were the gatekeepers. And I've had someone not refer a patient to me because of their perceived lack of ability to adhere to a research study. I've had that happen. So I think reaching out to the community and doing community outreach, partnering with the physicians and working with them is really a good step. I have the clinic in mid-Michigan. We're looking at other clinics. We perform community education routinely, like we have lectures online and that sort of thing. And I think that's beneficial and really engaging them. As far as funded fellowships, I mean, I think that's an awesome step. And those things have been available in the past, like fellowships that really target minorities. So in the academic world, I think we have to really reach out to people who might be interested and mentor them, encourage them to apply for fellowship. I somehow have been tagged as the person who will always have people shadowing in my clinic somehow. So I get many, many emails and I have people shadowing all the time. But those types of things make a huge difference if you make yourself available to people who might be interested in medicine. You might get more interest that way too. And again, if they see people like them, it really does help. Honestly, I'm not sure I appreciated that until I was a little bit older. I lived in this kind of small private school world all my life, and so it was a little bit different from like the real world. And so when I ended up in the real world at a place like Michigan, which is huge, you realize it took me a few years to actually realize I was the only Black person in cardiology. And we have over 100 cardiologists. And I'd assume someone who was affiliated with us was a cardiologist. So I think having that representation on every level, right? And then engaging people who might be interested, summer programs, that sort of thing, can really drive that.
So Monica, one final thing, and that's maybe the hardest question. I saved it for the end. Come on. So we all know, and I think we all embrace the idea that we need to improve how we do with equity and diversity, but especially when it comes to socioeconomic factors, psychosocial factors, those interventions are expensive. And in the world that we live in right now of really everybody having such a higher focus on cost and cost management, how do we marry those two? How do we, and I think this is a question that we have to ask all of us, but how do we as a healthcare system and as communities fund opportunities to increase support for people who are socially challenged, or help, insurance issues, or potentially have mental health services, or some of those things, are more social workers or more things. All those things are very expensive, but desperately needed to close the gap. Any thoughts?
This is the hardest question. And so, we end up, we will take a patient who is seemingly a good risk. They might be older. Medically, this is the challenge that I've had. We will have patients who are medically not good candidates, but they don't have any of the psychosocial issues that are really, really hard to address. So we put that patient through transplant, and they may end up having gazillions of dollars of complications on the other end. On the other hand, we may have a young patient who, great candidate medically, but has all of these psychosocial factors that we cannot address. It's really challenging to address. And I think, again, we have to, perhaps more research in that area and calling attention to it, trying to understand which candidate really is the better candidate. Is it this person who seemingly has good social support, otherwise not good medically, versus this really challenging person who needs mental health support, who needs medication support, who needs all of the supports. And I don't know that we know that, if you invest up front, what the gain is going to be on the other end. And can you compare those two types of patients? And I think we need data in that area. Yeah. All right, well, thank you.
Thank you so much.
Thanks for the conversation.